This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined as always by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. The title is quite provocative. To improve is to change, but is it safe? A single surgeon's transition from lateral to vertical hemispherotomy.
It's a classic Winston Churchill quote to start a paper, isn't it? But in the OR, change can be daunting, especially when we're talking about something as major as a hemispherotomy. For our listeners who are residents or students, we're talking about the functional isolation of an entire cerebral hemisphere, usually to treat drug-resistant epilepsy, or DRE, in children.
Exactly. And the paper sets the stage by reminding us that about 1 in 3 children with epilepsy will become refractory to medication. If they have hemispheric abnormalities, whether that's congenital, like hemimegalencephaly, or acquired, like a perinatal stroke or Rasmussen's encephalitis, then surgery becomes the gold standard.
We've come a long way from Mackenzie's first anatomical hemispherectomy in 1938. We moved to the functional disconnections proposed by Rasmussen, and now we're really focused on hemispherotomy, minimizing cortical resection while ensuring complete transection of the commissural fibers.
Right. And that brings us to the central conflict of the paper. For a long time, the lateral perisylvian approach was the established way, but recently, the vertical parasagittal method has gained traction. Some studies, like the one by Falah and colleagues, suggested that the vertical approach might actually provide better long-term seizure freedom and fewer complications because it requires less cortical resection and less time.
So the question this study asks is, if you're an experienced surgeon who is used to the lateral approach, can you safely switch to the vertical approach without your outcomes tanking during the learning curve?
That's the "but is it safe" part of the title. This was a retrospective, single-center, single-surgeon study. They looked at 36 patients operated between 2016 and 2025. Of those, 23 underwent the lateral perisylvian approach, and 13 underwent the vertical parasagittal approach.
Before we dive into the results, Alara, let's quickly visualize the two techniques for our listeners. The paper has a great diagram for this.
For the lateral perisylvian approach, you're looking at 5 main steps: suprasylvian disconnection, an insular undercut, infrasylvian disconnection, temporal disconnection, and finally the corpus callosotomy. It's a very around-the-middle approach.
Whereas the vertical parasagittal approach is more top-down. You create a window through the superior frontal gyrus to enter the ventricle. From there, you do the corpus callosotomy, then the insular undercut, and finally the temporal disconnection.
The study used the HOPES criteria, the Hemispherectomy Outcome Prediction Scale, to make sure they were comparing apples to apples. If you remember, the HOPES study identified 5 independent variables for seizure freedom: age over 3.5 at seizure onset, stroke etiology, no previous resective surgery, absence of generalized seizures, and no contralateral hypometabolism on FDG PET.
It's a high bar for comparison. So, Alara, let's get to the meat of it. When this surgeon transitioned from the lateral to the vertical technique, what happened to the patients?
Well, the headline result is that seizure freedom was remarkably consistent. At the 1-year follow-up, 90.9% of the lateral group were seizure-free, that's Engel Class 1, compared to 83.3% of the vertical group.
And statistically?
The p-value was 0.602, no significant difference. Even when they adjusted for those HOPES predictive factors using a binary logistic regression model, the chronological epoch, basically when the surgery happened during the transition, did not significantly impact seizure freedom.
That's reassuring for any senior attending thinking about changing their technique. But seizure freedom is only half the story. What about the efficiency and morbidity metrics the vertical approach is supposed to improve?
This is where the vertical approach really shone in this data. The mean operative duration for the vertical group was 340.9 minutes. For the lateral group, it was 448.8 minutes.
That's a difference of over 100 minutes, over an hour and a half less time under anesthesia. That's massive in pediatric neurosurgery.
It really is. And the intraoperative hemoglobin drop was also significantly lower in the vertical group, 18.1 grams per liter compared to 27.2 grams per liter in the lateral group. The p-values for both operative time and blood loss were 0.002.
So less time, less bleeding, and equivalent seizure control. What about the hospital stay?
Did the vertical patients get home faster?
Surprisingly, the hospital stay was about the same, 8.7 days for the vertical group and 9.8 days for the lateral group. Not a statistically significant difference there.
That makes sense. Postoperative management for hemispherotomy is often dictated by CSF dynamics and physical therapy goals, which might not change just because the surgical corridor was different. Now, let's talk about complications. Did the new technique lead to more strokes or infections while the surgeon was learning?
The paper reports no statistically significant differences in complication rates between the two. They looked at things like the need for a shunt or EVD, infections, and even the expected neurological sequelae like hemiparesis or homonymous heminopia. The vertical approach didn't incur additional morbidity, to use the author's wording.
Let's dig a bit deeper into the transition itself. The authors split the patients into chronological epochs to look for a learning curve effect. Can you explain that?
Sure. They wanted to see if the surgeon's earlier vertical cases were less successful than the later ones, but they found that even during the transition phase, the seizure freedom rates remained stable. This suggests that an experienced epilepsy surgeon who already understands the internal 3D anatomy of the disconnections can transfer those skills from a lateral perspective to a vertical one quite safely.
I think that's a key point for our resident listeners. The disconnection is the same goal. It's just the corridor that changes. If you know where the thalamus is and where the ventricle is from one angle, you should be able to find them from another, provided you have a sound grasp of the anatomy.
The authors actually conclude that while larger studies might eventually prove one technique is slightly superior to the other, the most important thing is for a surgeon to have a sound grasp of both techniques in their armamentarium.
I agree. Some patients might have anatomy that favors one over the other. For instance, if you have significant cortical dysplasia in the frontal lobe, the vertical SFG window might be right in the middle of your pathology. If there's heavy scarring in the sylvian fissure from a previous insult, maybe the vertical approach is actually safer.
And the vertical approach's reduction in blood loss is a strong argument, especially in very small children, where even a small volume of blood loss is a large percentage of their total circulating volume.
Definitely. So, to summarize for the folks at home, this single surgeon series shows that transitioning from the lateral perisylvian to the vertical parasagittal hemispherotomy is safe. It doesn't compromise seizure freedom, it doesn't increase complications, and it actually significantly reduced operative time and intraoperative blood loss.
It's a strong endorsement for the vertical approach, while also being a vote of confidence for the experienced surgeon to keep evolving. To improve is to change, as the title says.
Well, that's about all the time we have for today. Alara, thanks for breaking down the data for us.
My pleasure. It's a great piece of evidence for the field.
This has been the Neurosurgery Hub podcast. To our listeners, keep practicing, keep learning, and we'll see you in the next episode.
Stay sharp.